All right. Good afternoon. I'm honored to welcome you today to the fifth annual Allen Bisno Memorial and Infectious Disease Grand Rounds. We're so grateful to Allen's wife, Barbara, and Neil, who are here today for sponsoring this Grand Rounds each year. And it's a great opportunity for us to remember Allen's contributions to the University of Miami, to the Division of Infectious Disease, and really to the School of Medicine as a whole. While we think of Allen as our own here in Miami, he was actually first a legit Tennessean. He spent almost 2 decades in Tennessee, where he completed his internal medicine training at Vanderbilt. And after spending 2 years in the CDC EIS, he then completed his fellowship at the University of Tennessee and stayed there as faculty and eventually as the chief of the ID division there, and really developed international reputation for his work in Group A streptococcal disease. And so when he came to Miami in 1987, he was already a thought leader and a scholar in infectious disease. And we were so fortunate that he then spent more than 30 years here at the University of Miami School of Medicine as a professor and the vice chair of the Department of Medicine and the chief of the medical service at the Miami VA, where he led Morning Report, directed clinical services, and continued his research and mentorship. And when those of us who worked with Allen as house staff and faculty remember him, it is striking how many of us recall his personal touch and how he sponsored and advocated for us to learn to write our first author publication, and to get manuscripts out, to match into ID fellowship, to land a faculty position, and of course, to make sure that we never missed a case of necrotizing fasciitis. It's been a pleasure to have the opportunity to reflect on Dr. Bisno's personal and professional accomplishments with his family and with others in the division. And I would like to thank them again for continuing Allen Bisno's legacy of clinical, academic, and educational excellence with this Grand Round series. So thank you very much.
Good afternoon, everybody. I'm Joaquin Espinosa. I'm one of the chief medical residents for the internal medicine program. And it's my pleasure today to introduce Dr. Andrea Beaton. Dr. Beaton is a professor of pediatrics and a pediatric cardiologist at the Cincinnati Children's Hospital. She's also a founding member of the Rheumatic Heart Disease Research Collaborative in Uganda, where she leads global initiatives aimed at combating rheumatic heart disease. She holds leadership roles with the American Heart Association, the World Heart Federation, and the World Health Organization, where she served as a co-chair of the Rheumatic Heart Disease Guideline Development Group. Dr. Beaton's work reflects a sustained commitment to advanced research, strengthening global partnerships, and moving us closer to the elimination of rheumatic heart disease worldwide. Please join me in welcoming Dr. Andrea Beaton.
Well, thank you so much for that very kind introduction. And I'll just say another thank you to the Bisno family, to Barbara and Neil. We had a lovely dinner last night, and I was able to hear more about Allen and his legacy. And it is a true pleasure to be here speaking on the topic of rheumatic heart disease, which is my favorite topic, and something that Dr. Bisno held dear and really worked to advance science in his lifetime. So thank you guys for all being here today and for this lovely invitation. All right, just a few disclosures. We have research funding from many organizations and one consultant role working to progress the Group A strep vaccine. My other disclosure is a lot of the work that I'll present today does build on Allen's legacy, and it is a real lasting legacy that advanced the work on rheumatic fever and rheumatic heart disease during a time in the United States where there was really a relative pause. Not many people were working on this disease in the 70s and 80s, and Allen continued to be a champion, and we'll see some of the great advancements he made today. So our work all can be credited back to this continued engagement as well. And then also just to acknowledge that the work I'll present today is not just my work, it's the work of many partners around the world. This is the website for the Rheumatic Heart Disease Research Collaborative in Uganda that I have the pleasure of partnering with quite closely on our work. But also we have partners in over 35 countries that are contributing to this work globally. And so it's a huge thank you to all of the people around the world who are working towards elimination of rheumatic heart disease. So a quick roadmap for today. We're going to look quickly at how we got here. What is the history of rheumatic fever and rheumatic heart disease here in our country and the remaining burden in the world? We'll look at the evidence-based interventions. What are the things that we already know work for this disease? And then talk about some of the ways that we're innovating science, bringing modern techniques to rheumatic heart disease research. And then we'll finish with an implementation case study. How do we get what we know works out to the people who need it, which turns out to be maybe the biggest challenge in this disease. So first we'll look at what I call decades of dramatic decline. Why don't we hear more about rheumatic heart disease here in the United States? Well, we knew for a very long time, so back in the late 1800s, that there was a contagious disease under the umbrella of scarlet fever, which used to include rheumatic fever and rheumatic heart disease as well, and that it passed through households and communities and towns. Here you see warning posters that would go up on houses that had scarlet fever. We knew not to go there. This was contagious, and it resulted in a generation of children that were considered weak. We actually see these children in movies and literature. The little boy in Game of Thrones who's so disabled, that kid has rheumatic heart disease. These are kids who didn't live long, who got sick all the time. And we knew in the 1920s that rheumatic fever was the leading cause of death of individuals between the ages of 5 and 20 in the United States. This was the #1 killer of children in the early 1900s in the US. And in 1936, the year that Allen was born, there were more than 1,000 rheumatic fever deaths in New York City alone, and 8% of autopsies, 8% of people who were autopsied at New York Presbyterian showed evidence of rheumatic heart disease. This was an enormous burden of disease in our country. You also see, which I find fascinating, rheumatic fever all through children's literature, reflecting the gravity of this disease in this period of time. We see it in Little Women, we see it in The Velveteen Rabbit, we see it in Laura Ingalls Wilder's stories about people who suffer from rheumatic fever. But rheumatic fever really became an enormous issue in the United States during World War II. Because when we put our young troops together in barracks and crowded living conditions, we saw an explosion of rheumatic fever. Between 1942 and 1945, just 3 years, there were almost 45,000 cases of rheumatic fever in the Navy. And we were seeing rates as high as 25 per 1,000 troops affected, even 100 per 1,000 in some of the different barracks. During that time, we also saw some of the biggest discoveries in rheumatic fever happen. Alexander Fleming in 1928 discovers penicillin. In the 1930s, we established the role of strep as the initiating agent in rheumatic fever. And in 1935, we get sulfa antibiotics, another effective treatment against strep. But we didn't really have mass production of penicillin until World War II, where it became a very critical tool on the battlefield and opened up our ability to prevent rheumatic fever in the general population. And really interestingly, this is Dr. Jones, who wrote the original Jones criteria, our diagnostic criteria for rheumatic fever. His impetus for these criteria was actually to not exclude young men from military service. We were seeing rheumatic fever at such high rates. We were worried that it was going to impact our ability to have troops for World War II. And so in his initial writing, he says, my immediate stimulus is keeping young men in the military because it's creating a serious problem for our U.S. troops. The American Heart Association, a group that Dr. Bisno was incredibly important to, volunteering on their rheumatic fever committee between 1977 and 1992. That's a very long tenure of service. I'll say the max now is 4 years. So that was back in the glory days of committee service, as we talked about last night. But the American Heart Association was largely founded around rheumatic fever prevention. Heart associations that were working to prevent rheumatic fever came together to form the AHA, and their earliest research funding were grants around rheumatic fever. Here's some bulletins from the 1950s. Their dubbing of rheumatic fever as childhood's greatest enemy was a powerful advocacy tool in the United States. But thankfully, rheumatic fever and rheumatic heart disease have become rare diseases in the United States. Here, a commentary by Dr. Bisno, written in 1983, sums it up. Where has all the rheumatic fever gone? And what you see is about the 70s and 80s in the US, rheumatic fever has become an incredibly rare disease and has lost the interest and funding and innovation in the United States. But as you know, or we wouldn't be here today, rheumatic fever persists as a disease of disparity around the world. So, in fact, we've seen very little improvement in rheumatic fever and rheumatic heart disease prevalence and incidence in low and middle income countries. And in many places, the rates are still the same as they were in the United States in the 1800s. We know that rheumatic fever, 95% of the burden now remains in low and middle income countries. Here you can see the red and the orange lighting up in sub-Saharan Africa, Southeast Asia, and many countries in South America, where again, we have endemic rates of rheumatic fever. But we also know there's a persistent burden in the United States. While rheumatic fever and rheumatic heart disease are uncommon here, we see over 350,000 deaths from rheumatic heart disease here between 1980 and 2014. And the most striking thing is that RHD tracks other diseases of health disparity in our country. So you can see regions lighting up in the South where we know healthcare outcomes are not as good as they are for other regions, and also out in the Western states, largely in our American Indian populations. And there are areas in our country where mortality for RHD is flat or even increasing, which we saw in some of the rural counties in Louisiana last year. We also know that rheumatic heart disease remains endemic in many U.S. territories. So here you see some kids getting screened for RHD in American Samoa, where the rates are still 2 per 100 in pediatric populations. But things are really changing. So while rheumatic heart disease hit a lull in the 80s and 90s, we're seeing a renewed interest globally and a reinvestment in trying to get strategies out to the world to create the kinds of solutions that worked here in the United States. The American Heart Association has actually renewed its commitment to end rheumatic heart disease. So on the left, you see a history, the nearly 100-year war, talking about the founding of AHA to eliminate this disease. And on the right, the imagination of the American Heart Association on how everyone from their members to the global community can get involved in the fight. And the World Health Organization and the World Heart Federation have also taken major steps forward towards RHD control. In 2018, that's the World Health Assembly meeting to pass the first resolution to tell countries they need to reinvest in this disease. In 2024, we got the first guidelines that have come out of the World Health Organization on rheumatic heart disease prevention in over 50 years. And there's been a World Congress in Rheumatic Heart Disease. The very first one was in 2023. And if anyone's really interested, the next one's in November of 2026, really bringing together global communities, policymakers, governments to come up with action plans to combat this disease globally. So taking all of that history and all of this new momentum, what are the evidence-based interventions that we know about for rheumatic heart disease? What do we already know works? Well, here we need to look at the streptococcal chain, or the pathway that creates rheumatic heart disease, morbidity, and mortality. And most of you in the room will be familiar with this, but rheumatic heart disease starts as a simple strep A infection. I'll say strep A a lot because we're trying to rebrand group A strep in the RHD community. This is an intentional effort to try to make it more relatable. It's just kind of stuck for me, so I apologize. Group A strep, strep pyogenes, strep A. But it starts with a strep A infection, likely a sore throat, but we'll talk about some of those nuances in our fellow conference after this, that creates an autoimmune reaction, rheumatic fever, that causes lasting and permanent damage to the heart valves or the doors of the heart. Early rheumatic heart disease being silent changes in the heart valves, advanced RHD when you begin to hear murmurs and see clinical symptoms. And again, over the next 5 to 10 years, rheumatic heart disease often progresses to advanced end-stage disease and early morbidity and mortality. In Uganda, the average age of death from rheumatic heart disease is only 25 years. It's 28 years globally, so quite young, hitting at the prime of life. So there's a couple evidence-based interventions that we know about that really came from the 1930s and 1950s here in the United States The first is primary prevention. So treat the superficial strep A infections promptly and completely, and you can prevent 60 to 80% of rheumatic fever. Globally, however, that's extremely challenging to implement. There's a lack of affordable diagnostics. Most countries don't have tests for strep where kids present with these illnesses. Clinical decision rules have been tried many times and perform quite poorly for group A streptococcal infections. And children often don't present with group A strep infections because they're mild self-resolving illnesses and they don't warrant visits to healthcare centers in many communities. Here's where we need a strep A vaccine, and we'll get back to that. We also know at the very other end of the spectrum, tertiary care, cardiac surgery, and cardiac catheterizations that can improve valvular function are really effective. They're the most immediate way to save the life in front of you, but they're incredibly expensive as a global health strategy. And there's also a big capacity gap. It takes decades to build the kind of infrastructure you need for heart surgery and cardiac catheterization in low and middle income countries. So this approach is incredibly important. It's incredibly effective, but it's going to require multi-sector investment. And so today we're going to really focus on the middle strategy. The middle strategy is secondary prevention, which might be the sweet spot for global rheumatic heart disease control while we wait for a vaccine. So secondary prevention has the most research on how to make it practical in low and middle income countries. We make the case that secondary prevention can serve as a base program to build out more comprehensive services and also strengthen healthcare delivery for other diseases that happen frequently in low and middle income countries. So how are we getting these strategies out? How are we innovating strategies around secondary prevention? And then we'll look at that case study. I don't have a timer up here. I'm sorry. Just going to keep an eye on my time so I get you guys out of here on time. Okay, great. All right, first is if we want to implement secondary prevention, we have to find the people who have rheumatic fever. And it turns out that's really hard to do. So the Jones criteria, which we talked about earlier, were meant to be a placeholder. When Jones introduced them in 1944, we talked about this. They were meant to keep our young men in military service, not exclude those that did not need to be included. And there's a line in the Jones criteria that say, until we have a better diagnostic test, we can use these set of criteria, but it's coming. Don't worry. Just around the corner will be a better test for this disease. But despite 4 revisions, 2 of which have Dr. Beaton's name on them, he worked hard on them during his time at the AHA, these criteria have changed very little, and we don't have a diagnostic test for rheumatic fever. This is clinical criteria. We also know that over time, to fit the needs of the United States, each revision of these criteria until 2015 increase their specificity. We didn't want to include people who didn't have rheumatic heart disease, but they decreased their sensitivity. So they started to lose global relevance. In 2015, the American Heart Association re-looked at these criteria and created categories to improve sensitivity for high-risk populations. There was an acknowledgement that while we needed very specific criteria for low-risk populations, we weren't doing well for the world to make these criteria too specific. And so you don't have to read these, but in the orange box there you see on the left of your screen is going to be criteria for moderate high-risk populations. And what we see is that they lowered the joint criteria. There was real data suggesting monoarthritis was an important finding in low and middle-income countries. We added echo. So it used to be a clinical diagnosis of carditis. You had to hear a murmur, but we realized there was lots of subclinical carditis out there we were missing. So now echo is in the guidelines, and they lowered some of the minor criteria like fever and inflammatory cutoff. All of this to say, in theory, the 2015 revision was incredibly important globally, but it hasn't actually made much impact on diagnosing rheumatic fever because they're incredibly hard to implement in low and middle income countries. So what you see of the findings on this screen is that most criteria are very non-specific. So look at the orange criteria. Evidence of strep A. About 70% of kids in the low and middle income countries will have an elevated ASO titer when you screen the population. Everybody has seen strep recently. Joint pain, very nonspecific. Lots of infectious diseases, as you know, dengue, malaria. These kids come in with joint and muscular pain. ESR and CRP, markers of inflammation, not very specific, and fever, everybody, right? And so not many of those findings are specific. And then the ones that are specific in the orange there, subcutaneous nodules, erythema marginatum, which are the rash associated with rheumatic fever, they're incredibly specific, but incredibly rare. So less than 2% of kids, especially dark-skinned kids in low and middle income countries, present with those very specific findings. We also have a problem that you can't routinely assess most of the important criteria in a primary healthcare setting in a low and middle income country. So while you can find out about joint pain and ESR CRP in many areas, you don't have echo, you don't have labs to test for strep A diagnosis, a requirement to get in. And so you can't implement the criteria where kids show up with these symptoms. And so most rheumatic fever is not diagnosed globally. It remains a really uncommon diagnosis globally, despite a very high burden of rheumatic heart disease. In this surveillance study that we undertook in 2019 to 2021 in Uganda, was in response to the fact that people were beginning to question, did rheumatic fever even exist in low and middle income countries in the same way that it had here in the United States? And what we found, you can see these dots are really well spread out on the maps in 2 districts undertaking active community-based surveillance. So we set up rheumatic fever clinics. We did massive sensitization with radio and community messaging to bring kids in who had fever and joint pain. We found a pretty high incidence, so 26 to 48 cases per 100,000. That's about 50 times higher than it is here in the United States. But it's not high enough to explain that 2 out of every 100 kids are living with early cardiac damage. So even with very intensive surveillance, rheumatic fever is an incredibly challenging diagnosis. It's also an enormous opportunity cost. So we know in low and middle income countries, about 80% of patients come in with rheumatic heart disease only when they have advanced disease. In our pediatric population in Uganda, there's a 30% mortality within 9 months of diagnosis, which only reflects how late children are walking in with symptomatic presentations. And so one of the ways that we're trying to innovate for rheumatic fever is getting a new and better diagnostic test that's fit for purpose for low and middle income countries. So this map you can see is the ARC network, the Acute Rheumatic Fever Diagnostic Network. It's a network funded by the LeDuc Foundation that we lead out of Cincinnati Children's, which is searching for a new diagnostic test for rheumatic fever. It's a really complicated, very fun network that involves 13 partner countries. You can see there that we try to keep patients and families living with rheumatic heart disease at the center of this. We have recruitment sites in Brazil, Malawi, Pakistan, and East Timor, trying to get global representation for a new diagnostic test. And we've got biomarker teams in England and New Zealand and Australia, as well as virtual cores for case diagnosis and echo review. And what we see, the actual graphs aren't that important, they're preliminary data, but what we see coming out of phase 1 of this network is essentially any science that you apply to this disease can discriminate rheumatic fever from other overlapping conditions. We just haven't really tried. This is one of the first efforts globally to try to distinguish rheumatic fever. So you can see on the far left, this is using antibody profiling to tell the difference between rheumatic fever and other cases. In the middle, some RNA-seq work, a little bit hard to translate to point of care, but very interesting. You can also separate them out. And then on the right, you see work in complement coming out of Imperial College, also being able to separate definite rheumatic fever in that yellow from known alternate diagnoses in the blues to the right. So the next step in this network, very promising, all 4 candidate approaches are moving forward, is we have that globally recruited cohort, and the science teams are going to be applying their methods to the new standardized cohort we have and see if we can get closer to having a diagnostic test that's both sensitive and specific for rheumatic fever, which would be an enormous advancement and fulfill Jones's promise in his original criteria that said, don't worry, it's just around the corner. These are only a placeholder. So we also need to find rheumatic heart disease earlier. So moving on to the next topic. Like I mentioned, most people, children and adults, present with rheumatic heart disease at the end of disease. They're already at advanced or end stage disease. They already have cardiac complications when they walk into the hospital. But we can do a lot better. The problem is that early rheumatic heart disease is asymptomatic and clinically silent. And if you come in late, it's hard to benefit from secondary prophylaxis, which we know is effective. What we found out over the last decade, and where a lot of my early work was, is in screening echocardiography. We know that it's the most sensitive test for early rheumatic heart disease. In one of the very earliest studies, in the bar graph that you see there, you can see that echo screening picks up about 10 times as much RHD as clinical or oscillatory screening there on the left. This was introduced really early in 1996, but it didn't start picking up steam until fellowship, where I started my research around 2012. That's where screening was really taking off. And over the last 10 years, we figured out that screening can be accomplished quite practically in low and middle income countries. There's been good studies on workforce availability and task shifting screening down to nurses and other healthcare providers, that we can teach these providers to screen for rheumatic heart disease with very brief training, even down to a couple days of training. That the equipment costs are coming down. We now have very small portable phone-size ultrasound machines that can accomplish this screening and cost less than $5,000 a device, and that we can do it very quickly. So in Uganda, we've got rapid abbreviated protocols that take less than 3 minutes per child, and that there's also very high acceptability of screening. People actually really like to see their hearts. So high acceptability of screening in low and middle income countries. We also have new evidence-informed criteria. So as screening took off, people were using all kinds of different criteria to say what was rheumatic heart disease and what wasn't. Remember, these kids don't have a history of rheumatic fever. And we now have very strong evidence-based criteria that were revised in 2023 that standardize this approach globally. But we also know that scale-up of screening for a really long time stalled because we didn't know if early detection improved outcomes. It seems obvious that if you find children with early valvular disease and you put them on prophylaxis, they'll do better, but we needed a higher amount of evidence for that. And so one of the first things that we did globally was a randomized control trial, looking at kids with the earliest forms of RHD, these very minor valve changes, to see if prophylaxis would improve outcomes. And so we had a big group of people from around the world, 25 cardiologists and cardiology fellows from 4 countries came over to Gulu, Uganda. This is before we had as much local capacity as we do now there. And we screened over 120,000 children for rheumatic heart disease over 6 months. These kids were then randomized to either receive 2 years of prophylaxis or no prophylaxis. And we worked with the community to develop enrollment and retention strategies. We were talking about some of these ahead of time. These are kids in peer play groups, which is how we keep them engaged in the trial. And over 2 years, we had 97% retention and adherence to prophylaxis in this group. And what we found was really definitive. So antibiotic prophylaxis in these earliest forms of rheumatic heart disease resulted in a substantial reduction of progression at 2 years. So in kids who did not receive prophylaxis, we saw 8% progression. This is to moderate severe, clinically important disease at 2 years versus 0.8% in the group who did receive prophylaxis. And this was the last piece of evidence that the world needed to start advocating for RHD screening. So the results of this trial very rapidly shaped new global guidelines, and the WHO now recommends screening for rheumatic heart disease in high burden areas, just as of 2024. We're also now looking to generate the evidence of how can we best implement screening. So the only thing to take away from this slide is we're heavily overusing the acronym GOAL for all of our studies. It's getting quite confusing. But in this series of studies that we're doing in Uganda, we're trying to set up the standard of care for kids who have this earliest form of disease. So the trial we're doing now, called GOLI, is looking at intermuscular versus oral prophylaxis. Could we do just about as good with oral, which would be a lot more practical in low and middle income countries? And we're looking at the duration of prophylaxis. Could it be safe to stop prophylaxis sooner than 10 years or 40 or whatever long duration you take from the current guidelines to give more practical strategies to low and middle income countries? So we should know a lot more in the next 5 years about how to best care for these children in a scalable way. We also need, as we're thinking about big strategies that can improve RHD care delivery, is we also need to keep more people who know they have rheumatic heart disease on prophylaxis. And it turns out that that's really tricky globally as well. So registry-based care was just named in 2023 one of the most cost-effective strategies for non-communicable disease control globally. It's actually the only green strategy that made it through on the NCD best buys for the WHO strategy. But we know globally less than 60%, about half of people living with rheumatic heart disease are able to maintain protective levels of prophylaxis. It doesn't make any sense to find all of these kids if we can't protect them once we've found them. And so it's a huge implementation challenge. We know that registries historically were very important for people living with RHD. So the first RHD registries were here in the United States. There's a famous registry in Baltimore. There's a famous registry in Boston that really transformed RHD control in our country and also taught us a lot about epidemiology. We also know that registries are important for health systems that care for people who live with RHD. We need information about the burden. We need to know who needs more support within our patient population. And registries can help us with resource planning and disease-specific investment. So in this area, we're trying to innovate by using a mobile health cloud-based registry called the Active Community Case Management Tool. So this was developed with partners from around the world under an American Heart Association Health Technology grant to try to create a solution that would fit into low and middle income country health systems. What ACT does is it gives us individual patient care tools. So here you can see patient cards from Uganda, where this has become the national registry, that gives us a quick snapshot of our patients. It lets us know who's adherent to their prophylaxis, who's due for injection, and any major recommendations for those patients. It also gives us things like graphs of their INR. So patients who have more advanced disease, we can track over time. So we are able to see and keep patients in the range that's protective. We also have tools within the platform that support low-income country health systems. So here you see a surgical prioritization list. You can tell what interventions have been recommended, how many days pending they are, and health systems can see who is waiting within their system for more advanced interventions. We also provide quality improvement tools and tracking to look at facility and system performance and to help our health facilities set targets for improvement. So on the far left, you can see the RHD care cascade, which is modeled off the HIV cascade of care, looking at optimal delivery of interventions. And we have quality improvement tools built within the registry so that health systems can identify targets for improvement of care delivery, something that we're trying in Uganda right now. So looking ahead, in Uganda, the ACT registry has become the national platform that's used by the Ministry of Health. We're at 8 regional centers, and there's over 3,000 current patients in the ACT platform, over 200 users down to the primary care level. And what we're seeing is immediate improvements in care delivery by having access to data. So Collins, there on the left, is our national RHD coordinator for the registry. She leads a weekly quality improvement collaborative with the regional referral hospitals. And you can see 2 of those hospital graphs in the middle that show retention to follow-up for patients who are in the registry. You can see starting off, we were doing pretty poorly. We had about 60% retention. And that graph goes down quite nicely for both centers and has been able to be maintained on the number of patients who have not come back in 6 months to be checked by a cardiologist. We're also looking to scale out registry-based care. So we have 5 new partners that are implementing ACT this year, including a health system in Brazil, Ethiopia, Zambia, Pakistan, and the Dominican Republic and Haiti. So working to see how this registry is going to be adopted and implemented globally. We're also working on transitioning the registry into an open source platform so that countries can have better data ownership and can implement care in their countries without the assistance of Cincinnati Children's. So putting all this together, what are we doing in Uganda? What has worked and where are we still looking for gaps? So we know that even with all of that innovation, there's been low investment in developing and testing implementation models. The WHO guidelines were really exciting that came out in 2024, but there are over 100 implementation considerations that are mapped out in those guidelines, things that we actually don't know about how we implement those guidelines in low and middle income countries. So really a huge work plan. If anyone has an interest in research, you can go there, you can just pick one off the list and start working on it because we have a lot of questions we need to answer. In Uganda, the Ministry of Health, along with our collaborative, chose 2 strategies to try to implement. So echo screening, find more people who need the prophylaxis, and registry-based care, keep them on prophylaxis once we've found them. And we've created the Adunu program. Adunu means heart in the local language of the North in Luo. And it really builds on those 10 years of research, a lot of what I showed you on how we can get care out. The program is meant for districts to implement at the district level and is serving as a base program, again, something we can build on for other strategies. That's the Ministry of Health manual for the program. So what we're doing in this program is active rheumatic heart disease case finding. So nurses are trained on how to do single view screening echoes. They use echo in their clinics to screen patients who come through. They take it with them on community outreaches, vaccine campaigns, and also in school-based screening. When they find people with rheumatic heart disease or suspicion, they refer them to the district level clinics. And then those patients, once confirmed, are referred back to their primary healthcare center linked through the registry for prophylaxis. One of the most important parts of this program have been strong district health office leadership. So this program is owned by the district health offices with our teams as heavy implementation partners. But the DHO supports all of the activities, and they've named a focal person similar to strategies for HIV and TB in the community, where there's one nurse that sort of runs RHD programs under the ministry's guidance for that district. We've also put a lot of emphasis on deep community leadership for this program. So you can see on the bottom some of the community advisory boards, the open community forums that shape our outreach and education strategies, and even some early participatory design workshops that shaped our health education for this program, really trying to get deep community buy-in and investment. The echo training, and we were talking about this, some of us before we started, has been the most challenging aspect. It turns out you can teach anybody to screen in about a day, but it's hard to teach everyone. And so scale up of training has been really complicated. We have trained about 60 providers in the first district and achieved about 60% final certification. We've since modified this and achieved about 90% final certification in our second district. So we're still working out the kinks on how do we get everyone up to speed. But what we've seen with echo screening, and that's a graph of the public health screening that's happened in the district over time, is that once trained, the nurses enjoy the skill. And again, the community likes to see their heart. They receive the screening well. And we're finding more efficient ways to integrate screening into existing school health programs and community outreaches. So the district has screened, that was very early on, had screened about 14,000. They've screened now about 55,000 people living in the district for rheumatic heart disease. Skip that. And then we talked about registry-based care. So it's been really important to figure out the right implementation strategy for registry-based care. And it turns out there are health information assistants at all facilities who have been able to support the uptake of registry-based care. And then a biostatistician in the district takes that data and puts it into district-level reports. So our early outcomes. So as I mentioned before, we've taken the HIV cascade of care, which some of you may know about, and transitioned it to an RHD cascade of care. So we've got 2 different cascades that look at how do we optimally get people protected, which is here on the very far end. That's where you need people who have RHD to be protected from advanced disease. And what we see is there's drop-offs between screening and case confirmation on the far right. We're only getting about 80% of the people who screen positive in the community back for a confirmatory echo. And then in the treatment cascade, we're doing really well once you have a positive confirmatory echo, but there's a drop off between the first BPG injection, that second to last line, and people who remain adherent. So far what we've learned, this program's been running as a public health program for about 2 years now, that we've had strong success because of implementation support, healthcare worker pride and skill development, community trust and engagement in the program. But the challenges remain both with resource limitations and training challenges. I was telling someone right before, they do staff rotations every year where everyone just switches facilities. So that's been tricky to keep up with. Sometimes facilities end up with no one who knows how to screen. And that gap between positive screen and confirmation is too big for what we're comfortable with right now. We've also had some really big policy wins at the ministry level here. So these sometimes sound small, but are the result of an enormous amount of engagement and work with the ministry. The first is that rheumatic heart disease is now a notifiable disease in Uganda. It really should be everywhere, but it's now notifiable and it's built into the National Health Information System. So this is the standard form, HMIS, that districts have to report their metrics back from. And getting RHD added as a single tiny line on this form 105, has allowed us to track rheumatic heart disease. Now, most districts have no programs, and so most districts report 0, but it's become a metric that the ministry knows about and is seeing reports on. We've also been able to integrate 2 big wins into the National Non-Communicable Disease Strategy. They weren't the wins we wanted, but they're still good wins. So one was sore throat treatment and prevention. We've already talked about why that might not be the best approach, but it's what the ministry wanted added. So that's been added in. The other is reporting back on prophylaxis adherence. That's the one we really fought for, to make sure that patients who had RHD, that districts were accountable for how well they were maintaining on prophylaxis, which was something the ministries could relate to because they track HIV adherence to medication. And the final one was that in the national, I already told you that one, sorry. Go. Okay, so what are we doing now? Real quick, and we'll open up for questions. So we're working on ways to improve linkage to confirmation. This is Japhas Pule. He's our director of science at the Rheumatic Heart Disease Research Collaborative, but he's doing his PhD currently under a Fogarty grant to improve linkage to confirmation. So working really hard on how can we innovate from a positive screen to a linkage to confirmation. Also, one of our early career trainees looked at a program to use community health workers as case managers to keep people who are identified with rheumatic heart disease adherent. And what you can see here is that in usual support, the red dots, we had about a 62% adherence, about what we're seeing globally. But by the assignment of a community health worker, a cost of about $10 a month for a whole health center, we were able to maintain 98% of patients in that blue on prophylaxis. So we're working to scale that up within the Adunu program now. And we are looking at leaner models for scale. So really exciting. We've gotten a new grant that's going to look at how we can use lean engineering methods to reduce the costs of the elements within the Adunu program and then scale up both in Uganda and in 2 new sub-Saharan African partner countries, to see if we can develop scalable models, taking an effective model and making it scalable. So that's all coming. But before our conclusion, I just had one more thought, is that I'm not a vaccinologist, but this is probably one of the most exciting things that's happening in rheumatic heart disease right now. We have to continue to pursue a vaccine. And I just love this quote from Alan, which I found in a publication from 1977, preparing for this talk, where he said, nirvana for the streptocologist will be the day when an immunogenic, non-toxic vaccine specifically formulated to contain locally prevalent rheumatogenic strains are administered to persons who, on epidemiological grounds, are at greatest risk. I love that. Nirvana for the streptocologist. Like, that's such a great line. And he said, for the first time in many years, a reasonable basis for optimism. And that was in 1977. So I love the optimism. We actually haven't gotten that far since 1977, but things are changing rapidly. So we know that strep A, or group A strep, is the 4th most deadly pathogen in the world. And it is the only one on this list now that doesn't have a vaccine. And through my conversations this morning, HIV also has something really close now, right? Not a vaccine, but the twice yearly injection to prevent disease. Strep's got nothing right now. We're really far behind on this. Why is that? So there was this fantastic article in the Mosaic magazine on this bacteria we've been ignoring, why there should be a vaccine for strep A. And theoretically, all strep A infections and their immune-mediated complications could be vaccine preventable. But after decades of research, there isn't a licensed vaccine. And just as a brief, clearly I like history, but one of the major problems was that a kind of poorly designed case report showed that there was 3 rheumatic fever cases after a very early vaccine. This is back in the 1960s, and the FDA put a ban on human testing for strep A vaccines that was in place for 30 years after that. Everyone who goes back to this study thinks, oh, that was kind of uncomfortable. It wasn't well done. They were siblings of patients who had rheumatic fever, who got rheumatic fever. They were living in a rheumatic fever endemic community. There was an epidemic when this paper came out, but it led to a 30-year ban, which didn't allow any inhuman testing and really killed the industry's interest and the pharmaceutical company's interest in a strep A vaccine. Luckily, that's been lifted. And the field is now really rapidly moving forward. I know you guys saw Jim Dale as one of Dr. Bisnow's early mentees. He was actually one of my mentors when I first got started. His vaccine is moving forward. He's in the corner there. The WHO has published roadmaps to strep A vaccine development specifically for rheumatic heart disease prevention. The strep A vaccine consortium has formed and has gotten millions of dollars of funding, again, to move forward a vaccine for low-income countries. And a controlled human infection model has been successfully developed. That's Andrew Steer, who's been a senior mentor to us in our clinical trials as well, but he has a model for human infection, which can help us with vaccine testing. So really exciting. Maybe we'll get to that nirvana, but very exciting for the field. So finally, for our conclusion, rheumatic heart disease is a solvable disease. I hope I've made that point today. It's a disease of poverty and neglect and broken health systems. And I think I learned a lot from our dinner last night with Barbara and Neil, but I think a lot of what Dr. Bisnow embodied in life and in his work, you can bring to this battle against rheumatic heart disease. So what I heard last night is Dr. Bisnow has an unwavering commitment to health equity. He raised a child along with Barbara who fights for equity in the world, Neil. We need that for rheumatic heart disease. We need to make sure that the world is a fairer place for all children who live in it. The second is that I learned Dr. Bisnow made lasting and enduring and impactful friendships. So we need that. We need a deliberate investment in durable partnerships. That's what we're seeing with rheumatic heart disease now. Grassroots from low and middle income countries partnering with high income countries to make real impact. I love this story. Dr. Bisnow ran into a man named Ed Kaplan when he was first going, I think, to medical school. Neither of them knew they were going to do infectious disease. Neither of them knew they'd do group A strep, and they were both leaders in this field for the rest of their life together. That's the kind of partnerships we need. And we also need a responsibility to cultivate and promote the next generation. And I heard fantastic stories last night of mentors who made Dr. Bisnow's career successful, kept him out of the Vietnam War. Who knows what the world would look like if that wasn't true? And also how he did that for Geo and others in their careers going forward. And that's what we need for rheumatic heart disease. We have to continue to invest in careers, in interest in our young people, and make sure that we're continuing to build a generation of people who care about this disease. So it was such a pleasure to get to speak to you guys today and to honor Dr. Bisnow's legacy.
Thank you, Dr. Beaton, for a very inspiring lecture and for tying in Dr. Bisnow so elegantly throughout the discussion. So let's just say outside of Uganda, in a low resource country, how would you tell the ministers of health to prioritize the different things? Would you tell them to get a penicillin supply chain up first? Would you tell them to all get butterfly ultrasound equipment? Would you tell them to make sure heart surgeons are available? What would you prioritize first in terms of the minimal package?
Yeah, it's a really good question. There's a lot of good things to spend money on in health in low and middle income countries, right? There's a huge amount of gaps in the health system. For rheumatic heart disease specifically, the most cost-effective strategy currently is to find these kids with early disease because penicillin is so inexpensive. Now, supply chain is a different issue and it's incredibly fragile, and we could talk about that for another hour. But as long as we can get penicillin to low-income countries, getting kids with early disease on prophylaxis will keep most of them alive to live long and healthy lives. So that's
So
where
echoes.
Echoes it is. But I'm a cardiologist.
Any questions online? Dr. Gershengorn, you want to unmute yourself and ask your question?
I will try. Can you guys hear me all right?
Yep, perfect.
Oh, excellent. Thanks so much for a really interesting talk. I'm just curious, and this is not my area at all, so I'm sure there are many reasons that this is an ignorant question. But listening to what you're saying and the idea that penicillin is, as you described, so relatively inexpensive and all the challenges with screening, is there a case to be made for just prophylaxing all kids in high-risk communities without screening?
Yeah, in a room full of infectious disease physicians. I don't know your background. That's a bold question that I've asked and gotten shot down. So we do want to worry a little bit about antibiotic sensitivity and creating resistance. Obviously, the strep bacteria itself is really wussy. We've never documented a case of penicillin resistance to strep A. We're actually going to do a really interesting trial of penicillin to prevent rheumatic heart disease that's starting this year. Not because we think it's the right public health strategy for the world, but because we think it will shore up the evidence around the potential impact and efficacy of a strep A vaccine. So while it's an interesting approach, I know it hasn't gained from people smarter than me in infectious disease a lot of traction, and I think it's largely around antibiotic resistance.
Hi, Andrea. Rana Chakravorty, PedsID. Thank you for all your tremendous efforts. I mean, it's really remarkable what you've and your team have been able to do for children affected by rheumatic heart disease. I guess one of the questions, and I'm going to go back to pathogenesis, and you mentioned your collaborators at Imperial doing RNA-seq and that. Well, I've always been puzzled in terms of the pathogenesis with rheumatic heart disease. You start off with, bog standard group A strep infection, and then somehow you wind up affecting your heart valves and the rest. Is there any discussion based on some of the RNA-seq data and the genomic data in terms of getting a better handle on pathogenesis? And the reason I ask that is because obviously we're talking about vaccines, and then you worry about an exacerbation, and then the repeat of that 1969 ill-fated experiment.
Yeah, it's a really good question and something I almost intentionally avoid, because while there are some really strong feelings and thoughts and great research, including Dr. Cunningham, who I think presented to you guys last year, what we are knowing to be more and more true is we don't know. We don't know much about the pathogenesis, and the things that we thought were true maybe are, and maybe are only in part. There's clearly humoral and antibody-mediated immunity happening here. There's clearly an autoimmune component where we can see inflammation in the heart valves in children who have rheumatic fever. And there's clearly a ton we don't know. The genetics is coming down to the complement cascade, and that children may be more likely who have dysregulation genetically of their complement cascade to get rheumatic fever. Clearly, genetics is only a part of this disease. Environment is a huge contributor as well. But we're learning more, and there's 2 large networks currently on correlates of protection and pathogenesis that the LeDuc Foundation is funding, and we're hoping those really advance our knowledge in the next 5 years.
Thank you, Dr. Beaton, for amazing grand rounds. We appreciate your being here very much. I want to thank the Bisno family for allowing us to have these grand rounds. I want to remind everybody to check the chat and to check the QR code upon exiting for the MEC and MOC credits. And I wish you all a great day. Take care of yourselves and each other, and we'll see you next week.